chief complaint onset mechanism. We've got two big mechanisms that we really talk about. With the foot, our two big mechanisms are hyperextension of the great toe, so we passively push her into extension, worried about that plantar plate. Sometimes our toe goes side to side with a MCL, LCL, a sprained great toe, but the real definition of a turf toe is that plantar plate. So my foot came down, it goes down like this, right? Or I plant and I push off, and that's where I have a problem. So they're pushing off, toe goes into that hyperextension. The other one that we see is that axial compression. So my foot comes straight down. If I had axial compression, so long bone compression back up through my metatarsals, what is my injury that we're looking at?
Fracture.
Or Liz Frank. So I come down like that, I hit my foot down straight like that, and if they've got pain over the dorsal aspect of their foot, yeah, we do worry about fractures, but that's our main mechanism, Liz Frank. Remember that slide, it shows the foot going down like that, and this second bone that keyhole's in there, boing, is popping out like that. And usually there's a little plantar flexion with that too, or inversion, excuse me. So they'll invert like that, their foot goes like that, and they get that Liz Frank. Very, very common. Direct axial compression back up through the axis of my metatarsals, a little plantar flexion, bink, and it pops up. My stress fractures that I get across here is just run, jump, start, stop. Pounding, I can get metatarsalgia or that march fracture over that third metatarsal head. What's my mechanism for this base of the fifth? Run, jump, start, stop, lateral, turn, okay? Our football athletes are wearing cleats. Our soccer athletes, we don't see that many fifth metatarsal fractures, but they wear a shoe that's usually a half size too small, so it fits like a glove, right? Our football athletes, they terrible shoes. The cleats probably the worst shoe you could possibly wear other than a track spike, okay? There's just no support in those. And so there's a ton of pressure here on this lateral and the plantar surface right here, so that's where we get those. When it comes to the ankle, our main two that we get is plantar flexion inversion, okay? So we get this ATFL, calcaneofibular posterior talofib, and we can also get anterior and posterior tibiofib. Our other mechanism is I'm in neutral and then external rotation, or dorsiflexion external rotation. So I either come down on my own, very common, or on someone's foot, plantar flexion inversion. Or my foot is planted and someone hits me, okay? And I get that external rotation. So those are the two main mechanisms that you look for. Now in my real time, after chief complaint onset mechanism, so we know the onset, was it acute? What was that mechanism? Was it hyperextension? Okay, what did your foot do? Did it go in? So, and then where is their location? So we always got to know onset, mechanism, and then functional anatomy. Without ever putting your hands on them, you should have a pretty decent idea of where you're going with this injury. And the whole purpose of our evaluation is to rule out what we think it possibly could be. You've got to do the other things to make sure you don't miss something. Like with the foot, the Ottawa ankle rules, we've got to get lateral edges, right? Posterior lateral edges. And we've got to make sure that we don't miss the navicular and don't miss the base of the fifth. It'd be x-rays. So we'll talk about obvious deformity and swelling. That's the first thing that we're going to do. You're going to say, I'd look for obvious deformity and swelling. We can really appreciate that in the lower extremity, foot or ankle. Not usually deformity, but definitely swelling, okay? If we see deformity or we palpate deformity, what are we thinking? We're probably thinking a fracture and or dislocation. Our exam kind of ends, we splint as it is, and we send them off. So there'll never be a case on an exam that I let you out that easy. Okay? So it's not going to be over at that point. Okay? So we just know that that's kind of our emergent situation, that at the end of the slides of every one, I'll talk about on the field or emergency situation. So we just need to know But like, for example, what are the 3 things when we first get to an athlete? So the backbone of the class is the evaluation process. Before we even really get that evaluation process going, what 3 things do we do? We make sure the scene is safe, okay? So we're looking at ABCs, we're looking at all those things, and we're doing our assessment as we come up on them. What's the next thing we must do when we get to that athlete?
Calm them down.
We've got to get them to calm down. They're going to be upset. Everyone handles adversity in a different way, okay? So give them a few seconds to get everything kind of calmed down. Not to mention they're hurting. They're in a lot of pain. Usually that. Why does it get a little better here in a couple of seconds? I talked to you about 3 theories of pain.
Like gate control?
Well, what is gate control? I hit my head and I rub it. I override the gate, right? What's the next one? Central biasing theory, learned behavior, right? It's happened to them before, maybe. What's the other one? Our opiate release. So all of you have sprained your ankle at some point, right? You hopped around for a second, you said a few cuss words, and you thought, how am I possibly going to get back home? Maybe that was just me, okay? Because I'm a long ways. Of course, I get hurt that far away, okay? And then you kind of walk on a little bit. It doesn't completely go away, but, right, the fire truck got an alert, the fire station got an alert, boom. Your brain helps you out, so you get the opiate release. Where was it? Real-time aim. Okay, so obvious deformity, swelling. The next thing I do, I want to start on the lateral side. So we said this is the sinus tarsi, so we start at ATFL. I go calcaneofibular ligament. I go posterior talofibular ligament. Lateral malleolus, right on it, and that posterior edge. And then I'm going to come right in just above the lateral malleolus right there for anterior tibiofibular, posterior tibiofibular. Then I'm going to come over here on the medial side. Are you having any pain over here on the medial, the deltoid? Okay. Then I'm going to come up here onto the medial malleolus and that posterior lateral edge. Then I'm going to, so each one of those I'm going to ask them, are you having pain here? Is there pain here? A lot of times they'll get pain down into their foot as well because we've got the cuboid here. What was the percentage of getting cuboid syndrome? Low, 7%. Yep. But they still can sprain, ligaments down into their foot. So ATFL, calcaneofib, are you sore here? Are you sore here? Are you sore here? Okay, so I catch all that lateral side, then I catch all the medial side. Then I've got to come in here. How about here? Are you sore over your navicular bone? Okay, on acute ankles, a lot of times you don't see navicular pain, but later on we could see navicular pain come. So in your re-evals, you always want to make sure, still no pain right here. Then we want to go to the base of the fifth, okay? And make sure there's no pain with that. Ottawa ankle rules, okay? After we do that, what do we move on to? So palpations, we go to active range of motion. So pull foot all the way up for me, then push foot down. Now turn foot in or out. Did you get hit in the head too? No, just kidding. Okay, and then perfect athlete. Okay, thank you. Okay, now pull pull your foot back. Typical trainer. Okay, and then resist, and then push in. You're gonna turn in for me, and then hold, and then push out, and then hold. So we're gonna do tibialis anterior, tibialis posterior, and then peroneal brevis. Right?
So you don't have to check plantar flexion?
Nah, I usually don't.
Okay.
I usually don't. I just want to catch those 3 main ones, okay? And then, if I was worried about an Achilles type thing, but usually, when does our Achilles bother us with an ankle sprain? Acutely, not very much. But if she's got a really bad ankle sprain, we put her in a boot, right?
Mm-hmm.
Yeah.
And then at nighttime, she has a tendency to relax her foot. I'm going to see Achilles tendon soreness and posterior tib soreness later in my, let's say I had her in the boot for 48, 72 hours, and then all the soreness sets up back here. It's not that there could be some damage to those tendons, like if we do an MRI, you can see some fluid in those. She got those along with the ankle sprain. But typically our main damage is to the ligament structure and the stability portion. But those get sore just because they get tight and sore, and then all the swelling and shuts down and everything else. And that's why we gotta get that dorsiflexion back. Now my passive range of motion, so I go from MMT to passive. I want to see, is there any pain in end range dorsiflexion? Any pain in end range plantar? How about inversion, which is really an inversion talar tilt? And then eversion, any pain with that? And then I'm going to go straight into my my exams. So I'm going to do the drawer first. I've got her left leg, so I want to have my right hand underneath, my left supports. How many degrees do I have her here? 10 to 20 degrees, so we'll say around 15 degrees plantar flexion, and then I pull in that plane. See how subtle that is? Barely moving that. She's nice and solid. Then I take her into neutral, so I can use my forearm to take her to neutral position. I'm going to push up, inversion talar tilt. Okay? Then I'm going to switch my hands. I come here, I come up here, I'm just above. I do external rotation Kleigers at 0. And that mostly gets my deltoid. Then I'm going to put her in closed pack, dorsiflexion, external rotation. See how my hand stays stable, and I just barely push her. It's not a whole lot. I'm just going to barely push, and I ask her if that creates pain. Really looking for syndosmotic when I go up into the closed pack. Okay? Then, with my hand here, I slide my hand back. She's in neutral position. Eversion talar tilt, rock solid, doesn't move at all. Okay? Then, I place her right here. I start proximal fibula, and I work my way down, expecting there to be pain as I get closer down here. Okay? Severe located pain would indicate a fracture. If you had any indication she gets leg whipped, there's any type of palpation, bony step-offs or anything like that for that ankle fracture. But typically they're not going to be able to walk on that, many different things. But we can get a leg whip looking for that. But mostly with the squeeze, when we're talking about ankle injury, okay, I'm doing this for my syndosmosis, my syndosmotic ankle sprain right through here, okay? All right? All right, then once I get done with that, any tingling and numbness over the top of your foot, and then pull toe back for me. There's her extensor, hallucis longus. So I want to come right in there and palpate for the pulse, okay? And that is your real-time ankle. Doesn't take any time at all,
So we
right?
don't have to do the tap on the medial tibia at all?
No. Medial tibial percussion?
Yeah.
No, not in a real-time ankle.
Okay.
If I'm dealing with a lower leg and they're complaining of shin splints, then I come in here and do the
Okay.
medial tibial percussion. Okay? So real-time ankle, I'm not doing medial tibial percussion. If she had some shin splints, she's complaining of this shin hurting over here, we want to come in here, see where they're tender, and we can tap down through there, okay? And we can definitely do that and see if we've got some medial tibial stress, okay? So there again, if they were doing that, we'd find out, okay, what was your mechanism? Did you get kicked there? No, it just kind of came on over time. It started right here, but man, it's getting worse. Okay? So we want to make sure, what are our possible pathologies with this? Well, we could have from medial tibial stress syndrome. Is it a stress reaction? Does she have periostenitis, right? Does she have compartment syndrome? So we want to see if it swells, all those different things. So we follow the same format, right? So chief complaint, onset, mechanism, okay? Typically with that, with a runner, you might want to ask, because that's where you're going to see some of them, have you changed shoes, changed surfaces, stuff like that, especially with an insidious onset like that. So what have you done differently? And if they've done nothing differently, maybe they've increased their miles. Maybe they went from, we were running in the park, kind of on the grass, now we've moved to asphalt. So that's not going to change what we do other than in what we're looking for, but it might change how it helps them out in the future, okay? So that's how we do the real-time ankle. So what I'm going to do right now is you guys are going to get with your partner